morning, everyone. Let's start the Satellite Symposium, Optimal Treatment of Strategy for Patients with Longer Life Expectancy. I'm Joan Kim from Jeonnan National University Hospital from Korea, and this section chairman. And Kentaro Hayashida is world famous doctor for the TAVI. It's chaired by me with the join with the online. First, I will introduce the panelists who will lead the discussion. This is Jae-woon Kang from Seoul National University Hospital and Chae Sukwon Chae from VHS Medical Center for Korea, In-suk Kang, Iha Women's Hospital, Mokdong Hospital, Korea. And today's lecture will be the 20 minutes lecture and the 5 minutes discussion each word. So I will introduce the two speakers, and the Kentaro Hayashida will take care of the discussion. The first speaker was the Kan Su, Princess of the Wellness Hospital, Hong Kong, China. The title of the lecture is the last clinical evidence and how it impacts my practice. I wish you a good lecture, please, and come to the panelists.
So good morning. So can you see my slides? Perfect. Okay. So this is Kent from Prince of Wales Hospital. So in the coming 15 to 20 minutes, I'm going to share with you the latest clinical evidence and how it impacts my practice in the arena of TAVI. So here's my disclosure. So as we all know that transcatheter aortic valve implantation is really a very established treatment for severe aortic stenosis in patients at all risk level. However, the younger and lower risk patient is with increasing long expected survival is being offered TAVI nowadays. So therefore, the lifetime management of these patients is becoming very important. So the Achilles for TAVI in younger, low-risk patients would include first the valve durability, second, and also the feasibility of TAV in TAV if the patient requires a second operation. Third, in younger patients, the risk of conduction disturbance and also subsequent associated problems with the conduction disturbance will be also an important considering factor. Finally, it's also important on the feasibility of future coronary access in this cohort of patients. I will start with touching on the hemodynamic profile and also the durability of different valves. So when we try to compare the most commonly used two transcatheter valve with its hemodynamic profile, you can see the use of a balloon expandable valve, and when compared to its retrospective, correspective annular-sized self-expanding valve, there is consistently higher gradient in using a balloon expandable valve, so which actually implies the hemodynamic profile of a supraannular self-expanding valve is superior when compared to the balloon expandable valve, and this difference actually persists throughout from 30 days to 1 year. When we try to take a look at the mean gradient of more than 20, the use of a balloon expandable valve is 1.5%, whereas in the self-expanding valve is 0%. And when they go to around, it's 1.5% for self-expanding valve and 10.2% for the balloon expandable valve. And that difference actually persists throughout 1 year. What does this difference in hemodynamic would translate to? So when there's no direct comparison of these two valves in terms of a longer period of time, but when we take a look at the TAVI cohort compared to surgical cohort in a randomized controlled manner, you can see the use of a self-expanding valve when compared to surgical valve that is consistently and durable results in terms of hemodynamic results. and when it's compared to surgical counterpart. So the use of superior design valve has consistently bigger EOA and also lower pressure mean aortic valve pressure gradient when compared to surgical valve. And with this baseline hemodynamic, when we take a look at the 5 years of bioprosthetic valve stenosis, we've divided it as a mean gradient of more than 20. You can see, and the TAVR cohort is apparently superior to the surgical valve. And if we use an EOA index of less than 0.65, which is implying a severe patient prosthesis mismatch, and the surgical cohort actually has an 18%, whereas the TAVR cohort has around 4.9% only. So these all imply that the hemodynamic profile of a superior valve is actually superior to surgical valve. And that actually also translate into some part clinical endpoint. So when we take a look at a 5-year risk of structural valve degeneration, in a pooled analysis from the core valve pivotal high-risk cohort and also the Certavi cohort in the RCT subjects, you can see the risk of structural valve degeneration is obviously higher in the surgical arm when compared to the TAVR arm, around 4.4% compared to 2.6%. If we try to stratify this cohort of patients into different baseline annular size, when we define small annular as less than 23 millimeter, you can see the difference of structural valve degeneration is significantly higher in surgical cohort when compared to the TAVR cohort. This is also of particular importance in Asian Asian part of the world, because in general our patients has a smaller annulus. And even if we take a look at the larger annular dimension, although statistically not significant, but there is still a trend of having a high risk of structural valve degeneration in the surgical cohort. So the superior hemodynamic profile in the superior design valve has also implied a possible longer durability. So apart from the acute performance in usual anatomy, and this superior hemodynamic profile has additional benefit in case of valve-in-valve procedure, because the original valve is going to constrain the valve expansion, limit the annular size, and also is particularly important in patient that has small annulus. And as I mentioned, this is of particular importance in Asian part of the world and also in female patients. And this superior hemodynamic profile has implied a potential longer-term valve integrity because of a better gradient, a larger EOA, and a potentially less structural valve degeneration. So having said that, although there is a less risk of structural valve degeneration, but when we take care of younger patients, a second procedure we might need to plan ahead. This is important in terms of lifetime management. And the feasibility of TAV in TAV is a very, very hot topic. So the main concern why this topic is bring up is that there is a very important hurdle of a TAV in self-expanding valve because of its superannular design and also the default valve frame, and which subsequently will imply a risk of sinus sequestration, risk of coronary occlusion if we implant a second valve in. So that actually would affect the first valve choice. So as a result, the different implanter has a lot of concern in implanting a self-expanding valve in younger cohort of patient. Not until just last month, there is a study from published in JACC Intervention, which is the Redo TAV International Registry involving 42 centers in an international manner. And the study used a propensity score weighted analysis to study all TAF in TAF procedure in this 42 center, and they do the analysis in patient that has TAF in balloon expandable valve, TAF in self-expanding valve, and also they also do analysis according to subsequent valve in patient with a balloon expandable valve in TAF, self-expanding valve in TAF. And here is what they found. So you can see that if we analyze according to the initial valve type, the device success rate of TAF in balloon expandable valve versus TAF in self-expanding valve is actually comparable, around 71%, with a similar safety profile. And that is where corneal occlusion. And when we take a look at the analysis according to subsequent valve type, you can see the use of balloon expandable valve in TAF versus self-expanding valve in TAF has a significantly lowered device success rate, and the safety profile is actually similar. So this superior device success rate of using self-expanding valve in TAF is mainly driven by a lower residual mean gradient. Otherwise, the hard clinical endpoint of procedural complication is actually comparable in both cohort of patient. So the author actually concluded that the safety and mortality for reduced TAF were similar among patients with initial balloon expandable valve and self-expanding valve, whereas reduced TAF using balloon expandable valve versus a self-expanding valve for reduced procedure also had a similar early safety and also mortality rate. However, self-expanding valve had higher device success rate, mainly driven by a lower mean pressure gradient. Of course, this is just some hypothesis generation study because it's mainly a registry-based analysis. And the most important thing is the major limitation of this study is that it did not include all patients that required TAF in TAF. It just included patients that end up underwent a TAF in TAF procedure, which implies there might be substantial proportion of patient that has initial screening by CT or other mortality or be it transesophageal echocardiogram, and then they were excluded for undergoing a TAF in TAF. And the CT analysis could also have affected the choice of valve in different centers. So these are the major limitations of this study, but at least it shows us that in a selected cohort of patient, the initial valve choice and also subsequent valve implantation might not actually affect the clinical outcome in a pre-screening analysis. So the next important advancement is in terms of the leaflet modification. We all know that the use of basilica leaflet laceration technique might be able to expand the feasibility of TAF in TAF, but the basilica procedure is well known to be technically challenging, especially in less experienced center. There has been a new delicate shortcut catheter device now is enrolling in first-in-human study in Europe, and that could potentially modify the leaflet and also expand the feasibility of TAF in TAF in different kind of valve combination. So when we talk about the future TAF in TAF procedure, the next important thing is on the initial implantation result. Here brings us to the importance of conduction disturbance and also the importance of commissural alignment to facilitate future corneal access and also subsequent TAF in TAF. So we all know that the importance of membranous septum in terms of the risk of conduction disturbance, and with accumulating experience, now the implantation of self-expanding valve has reached significantly from its initial strategy. The cusp overlap technique has get wide adoption in different parts of the world. The principle is to accurately assess and achieve target implant depth by isolating the non-corneal cusp, and also to allow the valve to descend to target position to minimize the risk of interaction with the conduction system. So with the new change, the deployment now starts above the annulus with an effort to maintain valve position above the conduction system. and the valve is then slowly released with delivery catheter centered across the aortic valve to help with stability. So then with this implantation technique, we hope to achieve an accurate implantation depth without interaction with the conduction system. So the data that is very initial when the company tried to push for this cusp overlap implantation technique is actually very amazing. So the registered data from different centers has a consistently lower than 10% of pacemaker implantation, which is very significant when compared to the original more than 10 to 15% of implantation of pacemaker. So in last EuroPCR, the data from Emory also has a similar outcome. You can see when the implantation followed the cusp overlap implantation protocol, the 30-day pacemaker implantation rate significantly reduced from 11.5% to 8.1%, whereas the other acute procedure outcome is not significant difference in terms of valve migration, valve embolization, and also re-intervention. So the next important implantation strategy is on the commercial alignment. So from this picture, you can see that if the commercial pose is right in front of the coronary ostium takeoff, then if you try to get access to the coronary in the future, it will be very challenging. That actually has important implication in terms of the subsequent valve TAF implantation too. So as a result, the importance of commercial alignment is having lots of attention. And now the company advocates the implantation strategy change from a flush port facing 12 to 3/0 cord now. And that actually is arising from data from Tang that with this strategy, there is a consistently close to 70% of achieving commercial alignment with this self-expanding valve platform. So the new standard of practice now is to for the implantation of Medtronic self-expanding valve is to have it flush port facing at 3/0 cord when we insert the catheter, and then at airway projection we check the head marker at the outer curve, and also when we're doing the implantation to use the cusp overlap projection for the implantation. So to conclude, the lifetime management is important in younger low-risk aortic stenosis patient. The supra-annular self-expanding valve has superior hemodynamic profile, potentially less structural valve degeneration, and potentially longer valve durability. And TAF in TAF is feasible in selected patients, and the cusp overlap implantation technique can help reducing the conduction disturbance, whereas the commercial alignment increase visibility of future coronary access and also will help facilitate future TAF in TAF procedure. Thank you very much.
Thank you for the nice lecture. Now let's start the 5 minutes discussion. Please ask a question and comment from Kentaro Hayashida and the panelists, please. First time.
May I?
Hi.
Okay, thank you very much, Dr. So, for your fantastic lecture. And I really learned a lot from your lecture. And I'm very much interested in the hemodynamic performance. And apparently, Evolute has the better hemodynamic performance than balloon expandable valve, and with the lower pressure gradient. And when you think of the impact on and the mechanism on the incidence of structural valve deterioration, and what is the mechanism underlying between structural valve deterioration and better hemodynamic performance? How it impacts the longevity of the bioprosthesis? What is your thought?
Thank you for your question. So this is actually a very important question. So when we just take a look at the hemodynamic profile, that actually might not have a strong clinical effect, right? Because these are just figures. But the implication is that this figure actually implied the flow dynamic in different valve platforms. So in supra-annular valve design, the flow is very the valve expansion, because it's the valve leaflet is positioned at the supra-annular level, whereas we don't actually cut out the calcium of the native valve. So if the valve is positioned at the annular level, the circumrization of the valve is having some sort of restriction in a intra-annular valve design. Whereas if the valve is positioned at supraannular level, apart from a bigger EOA, the flow pattern is less restricted by the native calcium, and the valve expansion could be more circularized. That is actually more physiological. And this is actually signified in the previous animal model. When we take a look at the flow pattern of a supraannular valve design, the leaflet of the new TAVR valve in a supraannular valve design is actually having less sort of leaflet vibration when compared to the intra-annular valve design. And that potentially could reduce the risk of the new TAV leaflet degeneration. Although now there's ongoing clinical trial, but we don't have the hard clinical data, but that's one of the postulation. So this doesn't only imply a acute hemodynamic profile difference, but also potentially implied a longevity issue.
Thank you very much.
Okay. Can I have a question also?
Sure.
My name is Jun Kang from Seoul National University, and first, thank you for your wonderful lecture. And this is just an opinion of mine, and I think that all of the factors that we should consider when applying TAVI to younger age patients, they are all sort of intermingled together. So you talked about the pressure gradient, how to decrease the pressure gradient by using different valves or different techniques. But one of the other issues is paravalvular leakage. If we try to decrease some kind of paravalvular leakage by doing additional issues, then we usually use additional ballooning, which might lead to conduction disturbance by compressing the membranous septum. And also, if we use the cuspid overlap view to shorten the depth of the evolute valve, then that might lead to a difficulty in future coronary access in some kind of way because that blocks the coronary wall. So I think that all of these issues are sort of counterbalanced together. So in my personal opinion, I think that there should be some kind of major revolution in the current valves that we use, both the SAPIEN and both the evolute valves, to adopt these heavy devices to younger age patients and to make TAVI and TAVI more feasible.
So thank you very much for the comment. And this is exactly what I think. I mean, I always believe that the implantation or the implantation techniques is just one way of sorting out the problem that we are having, whereas the technological advancement is actually the final solution. So I do agree with you that there is some limitation with the current platform, be it the balloon expandable or the self-expanding valve. So as a result, we need to do some sort of technical advancement. So that's why R&D is very important. For example, as you mentioned, I don't think it's not possible to have a new valve platform that would allow you to orientate the valve into a 100% certain commercial alignment. I think this is not technically that difficult. So, but of course, we're waiting for the R&D to come up with a new platform.
Thank you.
Any other question?
I have one question. I'm Sowon Choi from Seoul Veterans Hospital. When we think about the cuspid overlap technique, we use this technique to implant valve high valve implantations. And when we think about TAVR in patients with longer life expectancy, we need to get the coronary access, future coronary access, and so when we implant valve highs, and when we think about future coronary access and second TAVR, and I'm still afraid of some difficulties when we do second TAVR and do future coronary intervention and high implant. Firstly we implant valve highly, and that might come back to some difficulty to do the coronary intervention. What do you think about it?
So thank you very much for your question. So I think the impact of the valve implantation on future coronary access, now we understand more about the valve platform. The main hurdle is still on the commercial alignment. Whereas the implantation depth, of course, it has certain implication because the catheter movement might be more challenging when we are doing the coronary engagement. But I think the commercial alignment is still the key to a future coronary access. And I would say the cusp overlap implantation techniques actually help us to isolate out the non-coronary cusp, avoid the implantation, allow the valve to descend, which actually reduce the risk of conduction disturbance. So the difference in implantation strategy is actually very significant compared to the older way of implantation. Apart from implying a high implantation depth, it actually, I would rephrase it to say that it allows you to implant at an accurate intended depth. The reason why I would say so is that you don't always implant that high. The target implantation depth is still 3 to 5. It's just that the old way of implantation sort of misleads you to implant the valve we think is at 3 to 5. However, end up is actually lower than what you intend to. Now with the cusp overlap implantation projection, because the LV output tract is elongated and you isolate the non-coronary cusp, so the implantation depth that you try to achieve is what you want to, what you really intend to. So, and that would consistently allow you to implant at a reasonable depth. So the reason why I say so is that sometimes when you're expecting you want to post-dilate the valve, at the cusp overlap implantation strategy, you don't implant as high as what you want. You might potentially implant slightly lower, let's say lower than 3, be it like 5 millimeter at the non-coronary cusp level. Then you proceed to post-dilatation because you're expecting the valve is going to foreshorten a bit. And you don't always implant as high as most of the cases. You implant at an intended depth. And and the conclusion is that with this cusp overlap implantation projection, the achievement of intended depth is more feasible. And if you have concern in certain cohort of patients, you might still use this implantation projection, but you might try to adjust the implantation depth according to your preference and also tailored to different patients.
Thank you.
Thank you. Any question for Ms. Kap?
Yes, Dr. So thank you for nice lecture. I'm In-Soo Kang from Mukdong Hospital. I ask a brief question about your practice. What is your most considering point if you plan TAVR procedure for young patient?
I think I would say in 2 different directions, but it's actually the same ultimate goal is the how in 10 years time how the initial valve is going to affect the clinical management of different patients, because we're expecting this cohort of patient is having a longer longevity, right? So this question would then imply that I would choose a valve that has potentially longer durability. And if the valve fail, whether the valve subsequent repeated procedure is feasible or not. So that's why I think these 2 things are interconnected together. So I would choose a valve that's durable and a future TAV in TAV is feasible, be it the same valve platform or switch valve platform in the second TAV in TAV procedure.
Yes, one.
Yes, I just have one more comment regarding the conduction disturbance and the cusp overlap view. Is the reason that we consider this technique is to minimize the conduction disturbance rate, but we usually say that 3 to 5 millimeters below the NCC is okay, but then is that really the adaptable length that is okay for the depthness? Because we don't know the membranous septum length. We don't know if we can measure the real membranous septum below the NCC that is okay to touch by the evolute valve. So one of the points that I think is that before just saying that 3 to 5 millimeters is okay, we should have a individual approach by CT scans or to see that the membranous septum length is okay for this patient, let's say for 2 or 3 millimeters, then the evolute valve shouldn't go below that length. And if this patient has a very long membranous septum, then we could slightly lower the implantation depth for additional future coronary access problems. So what I want to say is that shallow the better is, of course, one of the strong points that we can achieve by any kind of preventing conduction disturbance, but also that also should be an individual approach for the patient.
Thank you very much for the comment. I completely agree with your comment. I would say the development of TAVR is just like in the arena of PCR is just like the angio-guided world now. And now in PCR, we have IVUS and OCT to sort of make the procedure more perfect. And the individual personalized approach of having the analysis of membranous septum length and also tailored to different individuals' implantation depth is probably the future. The reason why the company advocate a protocol of having implantation depth 3 to 5 as a general practice is mainly for easy adoption of the practice. But I would agree with you that individualization is important. But nowadays, at this moment, we don't have a standardized protocol because, as you mentioned, the assessment of membranous septum length is still not a widely used approach in different individual center by the CT scan protocol. So, but I do agree this is probably a wide way to go of individualization.
Thank you, last lecture and the good discussion. And I introduced the last speaker. The second speaker was the Byung-Hee Hwang from the Seoul St. Mary Hospital in Korea. The title of the lecture is the Practice Consideration for Young Patients. I wish you a good lecture, please.
Thank you, Chairman. I'm going to show some case by cases. So in the area of extension of TAVR into low risk and younger patients, we have to solve valve durability issues and post-TAVI PCI and permanent pacemaker and valve. So first, durability. In NOTION trial, recent update from the NOTION trial, you can see that against SAVA, TAVI has half the rate of SVD versus surgery. And insight from the CoValve US pivotal and CERTAVI trial, you can see that Medtronic TAVI platforms significantly lower rates of SVD versus SAVA. And in valve durability, you can see that self-expand performs better than surgery, and self-expand performs better than SAVR and balloon expandable. And both self-expandable and SAVR perform better than balloon expandable. It was a study by 10 randomized control trials meta-analysis. And as we all know, that subclinical leaflet thrombosis after TAVR, this supraannular deployment has an advantage. And you can see that comparing intraannular TAVR to supraannular TAVR, intraannular TAVR has a relative risk of 2.03 of associated with more risk of subclinical leaflet thrombosis after TAVR. So in terms of durability and hemodynamics, you can see there is an edge towards self-expandable valve. In post-TAVI PCI, coronary access after TAVI, prevalence of CAD is around about 50%, and treatment strategy at the time of TAVR is unclear, and about 25% underwent PCI pre-TAVR. Acute coronary syndrome after post-TAVR, you can see 10% had ACS and 20% had 2 or more ACS episodes. So between balloon versus self-expandable valve, you can see acute coronary obstruction can be in balloon expandable valve more, but we all know that difficulty of post-TAVR coronary access is more difficult in self-expandable valve. So goal is to aim to get the CTAP at the inner curve so that we can get the optimized commercial alignment. And we can get this inserting the delivery system with the flush port to the patient's left side away from the operator at 3 o'clock, inserting into the patient. So there's steps for angio and PC after TAVR. It's self-expandable stent. You can identify the coronary takeoff points by using eltography in pigtail, and you can see target coronary access zone. And then guiding catheter must be entered into the neosinus, and you can see 0.035 JT specifier to put the guiding catheter into the neosinus. There's of course some cases we have the guiding catheter goes besides the valve, but sometimes it can the technique will be needed, but usually guiding catheter must enter the neosinus through the aorta. So as you can see, guiding catheter, we should choose one size smaller than native L2 route in self-expandable stent using JL or JR. And second line is Ikari. High backup catheter like EBU and XP are not recommended. And balloon expandable stent, you can use standard catheter to engage coronary arteries. So stabilizing guiding catheter is important in during post-TAVI PCI. You can use double wire technique, balloon anchoring technique, and using guide extension catheter. I usually use all these techniques together. So I'll show you a case. Pre-CT evaluation was perimeter was 87.1 millimeter. We chose Evolute R, 34 millimeter. You can see there's a risk of RCA obstruction, heavy calcium in the ST junction level. So we took pre-TAVI, RCA. We had difficult to engage in RCA with JR, so changed to Ikari right and took the angio. So we took the coronary protection before TAVI procedure and slowly implanted the valve. Final implant, we watched about 5 minutes to fully expand the self-expandable valve, then check for echo. You can see the wasting, so we did post-ballooning. So the final angiography was optimal. Then we checked the RCA ostium, and you can see there's a obstruction in the RCA ostium. TIMI 1-2 flow, RCA obstruction was there. So we put a guideliner deep engaged with balloon anchoring and put a stent into the RCOs and check the IVUS. And the final eltography was good. Angiography was good too. And there is this model called Heartroid in Korea. It's a model from Medtronic, and you can use this device to put the device in your cat room and make some tries to get guiding the coronary arteries. I think this is it's well made, and if you can get the relationship with Medtronic, I think you should put it to your cath room and use it. So next, pacemaker. So how to avoid new permanent pacemaker implantation. So there's our clinical factors and anatomic factors and procedure and operator-related factors. So cost-of technique has been discussed earlier, and I will skip this. Okay. So cost-of technique is start higher, allow the valve to descend, control pace to point of no recapture, and then confirm death in the cusp overlap view, then go for the aerial frame parallel view to confirm depth, and then release slowly. In our institute, after cusp overlap technique, before about 10% of pacemaker release had decreased to about 5%. And we use another technique with this COT method, and this is a pre-CT review. Perimeter was 83.7. We chose Evolve 34 millimeters. Slowly deploy the valve, let it descend, and you can see that NCC side zone, almost zone 0. Then we can gently push the delivery system. As you can see, the valve goes inside. So push the delivery system before zone 0. After post, it can be delivered into the optimal site. As you can see, the final was very optimal. Another case of TAVI 24 pre-balloon did not cross, so we did 12 millimeter with peripheral 3D balloon after pre-ballooning it, and implanted with cusp overlap view. As you can see, zone 0 or 1 millimeter. This case was doing by gently pushing. As you can see, after the pushing the delivery system, pre and post, we found a very optimal position for the valve deployment. So gentle pushing before final valve release can be an option for optimal positioning in self-expandable valve. Next is valve-in-valve. So younger patients are treated by TAVI. A 70-year-old TAVI patient 10 years later, 60-year-old TAVI patient 10 or 20 years later. So we need for valve-in-valve in TAVI patients. So I'll show you another case. This case is not that traditional valve-in-valve after. This is an acute valve-in-valve case, but I think this was a complicated case, so I'm going to share it with you. So aortic annulus perimeter was 77.8. Check the autogram, pre-balloon, and gently put the valve. But there's no image here, but at the last moment, the valve went into the alveolar, so it was very deep. As you can see, maybe the mitral valve is, so you can see the valve is with almost near the mitral valve. So we gently wanted to reposition try with snare, but the device did not come up. So we checked for other problems, but there was no functional problem with mitral valve, and there was no PVL, so we stopped the procedure. So we checked the final position, deep, but there was no block, no PVL. So vital sign was stable, so we stopped the TAVI. And patient discharged, but patient back to ER 3 days after discharge due to severe dyspnea. You can see pulmonary edema, and there's a moderate PVL. So check the first TAVI final angio. Second TAVI initial angio showed almost better, but you can see increased PVL. First, we second tried for valve repositioning, but you can see the valve does not come up. It goes with the aorta, and the valve whole system goes up. So we put a pigtail into a crossing AV, and we did a VIV. Valve-in-valve in self-expandable valve, sometimes the second valve does not go easily into the first valve. So as you can see, you can see Lunderquist for extra backup, And you can see this snare to make the axis to put the second valve into the first axis, because if there was no snare, the second valve tip goes into the greater curvature to the first valve, so it doesn't go over the valve. So in this case, snare was needed. After the valve goes over the first valve, then you can retrieve the snare and gently deploy the valve. So using snare may be essential for crossing second valve and valve in VIV TAVI. The pre-echo, you can see at the post-echo, PVR has been disappeared. So this is my take-home messages. Durability and hemodynamics. There's edge on self-expandable valve, but it needs some cost. Post-TAVI PCI, permanent pacemaker. So post-TAVI PCI, self-expandable, you need guide catheter one size smaller than native L2 root, and JR, JR, or EBU and XP is not recommended. And almost double wire balloon anchor and extension catheter is almost important. And if available, heart rate can be a good option to learn. And to avoid new permanent pacemaker implantation after TAVA, I think cost overlap technique is essential. And gentle pushing before final valve release can be an option. And valve in TAVI, using snare may be essential. And coaxial with the L2 valve is very important, and it requires a high degree of precision by the operator. Thank you for your attention.
Thank you for a nice lecture. We open the open discussion. First, from the Kentaro Shaista.
Okay, thank you very much, Dr. Wan, for your wonderful lecture. Actually, I'm very much impressed by your negotiation with the low implanted valve. And finally, you put the second valve. And I guess that the mechanism for the PBL was the super skirt mechanism. That means it cannot be improved by the post dilatation. And your decision to deploy the second valve is quite important. And when we do that, we need to also be careful for the risk of the coronary occlusion. And how did you evaluate the risk of the coronary occlusion when you do the second TAB procedure for this specific case?
We put the alignment together, and before in the CT, we simulated with the second valve to not getting to make an obstruction in the coronary.
Congratulations. Thank you.
Can I have a question for Dr. Huang also? This is about the first case that you showed to us. I know that your institute is very experienced in doing TAVI procedures, and can I ask, what did you consider for the reason that the RCC might have been occluded in the first case, because you had a guiding catheter before the TAVI procedure? And the question is, are there any specific factors that you consider as a high risk for coronary occlusion in considering TAVI? And the second question is that you inserted a stent after the TAVI within the same guiding catheter, then that means that the coronary stent is somehow outside the original TAVI valve. But if this patient was not hemodynamically crashing, probably you could have accessed a new guiding catheter into the neosinus, which may make the stent sort of more natural without being outside the TAVI valve.
Oh, nice comment. Yeah. I think the risk of coronary obstruction is that everyone knows that the height is important, and that distance ratio between the height and the calcification of the original valve is important. And you have to see the CD image for calculating the risk of coronary obstruction. And this case, actually, this PCI was initially done by our one of our fellows. And the guiding catheter accidentally retrieved back to the aorta, and then we wired it again. So this case is not that through the side, but if the vita is very stable, I think, as Dr. Gong said, you can rewire through the neo sinus together. But as in this case, even if the stent is besides the frame, you can see in the IVUS that the stent is fully retrieved to the aorta, so that the frame and the stent does not interfere together. I think putting the stent more proximal so that the frame and the stent doesn't not interfere is the most important thing.
Thank you.
Do you have any question?
I'm Sowon Choi from Seoul Veterans Hospital. I have one question, and I'm so impressed by the pushing the high implanted valve before final release. And is there any impact on conduction disorder?
Conduction disorder is not impacted by that. I think conduction disorder is very complicated factor. So just gently pushing the device does not make any blocks or any EKG changes. But not every patient can be pushed, but about 60 or 70%, we put the valve very shallow and gently push the device. Then about 60 or 70% goes very smoothly, about 3 or 4 millimeters. I think it can be done very safely with gentle pushing.
Dr. Hang, thank you for this lecture. I have one question, especially the last case is very impressive, and I want to know your consideration for the second valve choice, and is there any room for the consider balloon expandable valve for the second valve in this particular case?
Very nice comment. And as Hayashi just said, the mechanism of the PVL is probably due to the space between the skirt and the aorta. So putting a balloon expandable valve, the exact position of making that PVL we thought that it might be very difficult. So more skirt, so a little bit longer skirt can disappear the PVL. We thought that we chose the self-expandable valve.
For considering the self-expandable valve, again, I also think that because of the self-expandable valve has a waist, it might be very difficult to select the adequate size of the balloon expandable valve for the second valve, because if that size was based on the original aorta, then that would deteriorate the size of the configuration of the first valve, which will make it very difficult for sizing.
I ask a simple question, more difficult. Your topic is a practice consideration for the younger patients. So if the younger patient, which valve selection, why and when?
Yeah, very difficult question. I think that from the durability and hemodynamic problem, I think self-expandable is a choice. But as you can see, after coronary access problem, permanent pacemaker problem, so it has to be decided by patient, I think.
Can you your keynote the case by case is very simple, but when the selection the balloon expandable and when the selected the
I think the ratio is older patients and younger patients, we decide between self-expandable, balloon expandable. I think younger patients, I personally prefer the concern of post coronary access. So I think younger patient, we may need some balloon expandable valve, I think, but I think it's by patient by patient.
Do you have any question or comment? So last the comment and the closing remark for the Kentaro Shihayashita. So last comment and the closing remarks.
Yep, and thank you very much, Professor Kim. And thank you very much, Dr. Wan, for your fantastic lecture. And I'd like to close the session. And today we have the two distinguished lecture. And Dr. So provided the latest clinical evidence based on the huge data, especially hemodynamic performance and valve durability. It was so educational. And Dr. Wan also demonstrated the very practical guidance for the coronary access as well as the bailout procedure. And I personally learned a lot from his lecture. And this year, this is the 20th anniversary from the birth of the TAVI procedure. And now indication is shifting towards a younger and lower risk patient. And that means now we are treating the patient who can be easily treated by surgical AVR. That means that we need to aim perfection. And the better hemodynamic performance and avoiding prosthesis patient mismatch is quite important. And mitigation of the risk of the permanent pacemaker is quite important. And today we learned a lot about the cusp overlapping technique to mitigate the risk of the permanent pacemaker implantation. And everyone talk about the lifetime management and the coronary access after TAVR procedure. And we also need to learn a lot about it in the future together. And I would like to thank my co-chair, Professor Kim, to chair this session. And I also would like the distinguished panelists, Dr. Kam, Dr. Choi, and Dr. Khan. And I also would like to thank the very great presenters, Dr. So and Dr. Wan, for their fantastic lecture. And last but not least, I would like to thank the Medtronic Korea and Asia for supporting to this session. And I would like to close this session. And thank you very much for joining this session. And have a nice day.
Thank you.